Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Nirav Pandya from San Francisco, United States. Dr. Pandya is a pediatric orthopedic surgeon and sports medicine specialist within the UCSF Department of Orthopedic Surgery. He's also the section chief of the Division of Pediatric Orthopedics. Originally from Chicago, Dr. Pandya received his undergraduate degree at the University of Pennsylvania in Philadelphia. He then completed a fellowship in pediatric orthopedic surgery at Rady Children's Hospital in San Diego, California. Dr. Pandya has authored over 60 peer-reviewed publications and multiple book chapters and speaks regularly at national and international conferences. If you notice, Dr. Pandya has delivered a couple of lectures on our channel, which were really engaging and have reached a wide audience all over the world. And today it's my great honor to bring back Dr. Nirav Pandya for this wonderful live program. Over to you, Nirav.
Great. Well, thank you very much. Well, today I'll be talking about overuse injuries in the young athlete, which is a problem that we see very frequently. The goals of this talk will be the following. Number one, we'll talk about epidemiology of sports injuries, which will help us understand a little bit more where a lot of these injuries are coming from. Then we'll give a general global approach to pediatric sports injuries, pretty much concentrating on the overuse variety of injuries. And then we'll talk about some of these top overuse sports cases. We'll spend a lot of time on the Apophysitis injuries, such as Osgood-Schlatter's, Sever's, and Syndergaard-Johansson syndrome. We'll spend some time on anterior knee pain, which is a very common complaint that we see. And we'll spend some time, what we call here in the US, Little League shoulder and Little League elbow, which are overuse injuries of the upper extremity. Now, one of the important things that we're seeing in multiple countries is a increase in sports and overuse injuries in young children. And one of the great websites that I encourage anyone who has more questions or wants some information for their patients is this website called Stop Sports Injuries. It's put together by various pediatric and adolescent sports physicians. And it's a wonderful site. But one of the things that they notice on here is that they state that 50% of all athletes will suffer at least one significant injury a year in the pediatric population. And the vast majority of that stems from some degree of overuse, whether that be the overuse injury itself or a traumatic injury that actually occurs due to overuse that has preceded it. And the epidemiology here in the United States is that there are 5.5 million children who are involved in in-school sports, but 30 million children involved in out-of-school sports. And that's where a lot of the overuse occurs because kids have taken basically the environment in which they play sports from an organized setting where they are currently and transitioned away from unorganized setting where more body parts are used and there's less overuse. And this has occurred with a drop in school-based physical education, with only 29% of high school students participating in daily classes. So a lot of what's happened is that free play sports where you can basically just play based on hanging out with your friends or doing other activity has disappeared, even in the school setting, has not been replaced by these private for-profit run entities in which overuse is very prevalent. So the problem that we're seeing, we have a high group of very specialized athletes whose goal is from a very, very young age to continuously kick a soccer ball, throw a baseball, play a lacrosse ball, and that's all they do all the time, and they get injuries as related to that. And a whole nother talk could concentrate on this whole group of kids who don't have access to physical activity because of this change, because they can't necessarily afford to play sports or aren't potentially skilled enough to compete with a lot of these teams. So the problem that has led to a lot of overuse is this concept called single sport specialization, which is intensive year-round training in a single sport at the exclusion of other sports. So at 8, 9, 10 years of age, a lot of these individuals will say, I'm just going to be a baseball player and that's all I'm going to play year round. And that's where a lot of these overuse injuries come from. And is the key thing for us as clinicians to identify is look at the participation patterns of these children and counsel them this should be playing in a different way. Now, a lot of this stems from the 10,000 hour rule. And there's a psychologist, Erickson, who said that in order to achieve expertise as a musician, one must practice 10,000 hours within that specialized field. And now that's been transferred over to sports, where kids feel that in order to succeed, they need to constantly and repetitively do more and more sport. And that's what's going to lead them to be successful. But as a result, an outgrowth of this is that with kids specializing in sports at an earlier age, we're seeing that extremely young group of children that under age of 14 experiencing overuse injuries. Their immature bones, the insufficient rest after injury, and poor training and conditioning contribute to these injuries. And they really have no outlets for free play or recreational leagues because of their money. So as a result, they either choose to overuse their bodies or they're not active at all. And a lot of this here in the United States has to do with the business of youth sports. And the problem is that whenever there's money intertwined with many of this, it can become very problematic where these entities who are trying to basically have money invested in it, and they give a lot of false advertising, which leads to kids overusing their bodies. And as a result, the most important thing that if you take home from this talk is that free play is no longer encouraged. The best way to prevent kids from overusing their bodies is to have them just play in an unstructured fashion. So I've never had a kid come into my clinic that I can remember over the past several years who is free playing too much. Most, if not all, the overuse injuries are due to the fact that kids are playing too much in a structured environment rather than doing things in which they're just out and playing on their own with their friends. And as a result of this culture, we have kids who basically then play up until age 13. They're subsequent to all these overuse injuries and they drop out of playing sports. And a lot of the reasons they give are due to adults, coaches, and parents creating this environment in which their bodies are being run down and they're basically not able to actually participate because they're either hurting or they're not enjoying their sport anymore. Now, really quickly, before we go into specific pathologies, I wanted to touch base a little bit on what may be driving some of this specialization, which is very commonplace here in the United States. And a lot of that has to do with the average cost of higher education. And recently, the average cost of college here in the United States was noted to be $200,000. And that's a large financial burden for a lot of parents. And as a result, there's a push, in addition to the way that how sports are offered here, to basically have children get the scholarship so they can become a professional athlete or get to college or get a scholarship. And I think it's important to counsel parents that this whole push to play sports all the time, 24/7, just constantly out there playing skill, doesn't necessarily lead to any differential in terms of success. So if you actually look at the number of high school students who actually go on to play professional sports, it's only 0.006%, even though every parent at a young age thinks their kid may have the possibility. If you look at chance of actually obtaining a college scholarship, it's only 2%, which once again is very, very low. And the average scholarship amount is only $11,000. So even if these kids are able to make it through, they're able to stay healthy, the vast majority of them won't even get a financial reward that may potentially even be worth all the hospital bills and all the money they're paying to travel from place to place to play sports. So I think it's important to counsel parents in this, so that they understand that the benefit of playing sports, and this can be any sport, whether it be soccer or cricket or other sports all across the world, is that the number of athletes who actually make it to that next level is so small, and the ability to gain financially from it is so small that it's not worth the injury risk or beating down your body at this young age. So you know that specializing in sport doesn't lead to athletic scholarship, it doesn't lead to professional success, but what it does lead to is burnout, overuse injury, and the mental health issues, leads to social isolation. And more importantly, one of the things to worry about is that if you start getting overuse injuries at age 9, at age 10, or age 11, you're less likely to have be participating as an adult in athletic activity, so it has downstream effects on adult health. So let's look kind of closely at some of the data. And there's this great book written by David Epstein, who's a author, who wrote that elite athletes in his research found were specialized in sport much later, more likely to play multiple sports throughout high school. So even if you feel that your child may have that possibility of going to the next level, it's probably better for them to play multiple sports to prevent overuse injuries. There was a study done by this researcher named Franson, who looked at boys aged 10 to 12 and found that those who spent hours in various sports were actually better athletes, beyond the fact that they were less injured. So I think that's important to note as well too. And then Holt looked at actually athletic performance in Germany and found that children who are of higher socioeconomic status were more likely to have more overuse injuries due to less free play. So it's almost a function of parents who feel that they need to more or less guide their kids' activities, quote unquote, we call here in the US helicopter parenting, who are leading the kids to have more overuse injuries. They're getting in these structured environments, they're injuring themselves, and they're not free playing. So the most important thing you can do to prevent kids from actually getting these is not necessarily an hour recommendation, which I'll talk about next, or some sort of special exercise or stretching. It's really just encouraging kids to free play, just play on their own, play with their friends, play recreationally, and not necessarily do something that involves a lot of structured activity. And this is a study done at the collegiate level, which once again, it brings home my point, that found that the vast majority of people who actually do achieve athletic success play multiple sports. So part of that has to do with the ability to transfer skills to other sports, but potentially even more importantly is the fact that playing multiple sports keeps these individuals healthy and prevents them from actually getting injured, because the only way you can actually perform at the next level is not to have overuse injuries and to stay healthy and not be burnt out. And finally, a lot of people will ask, how many hours per week should my children be playing sports? And Nirav Shayanti, who was a researcher, he was at Loyola, who's now down at Emory in Atlanta, did this great study that's quoted by a lot of us, where he looked at over 1,000 athletes and found that athletes who spent more hours per week playing their sport than their age were 70% more likely to experience severe injuries. So I think this is one of the important take-home points for this talk, is that a lot of parents will ask, that's fine, I don't want my child to have an overuse injury, but how many hours per week is it safe for them to do? And this is a great study that guides that. So for a 10-year-old who may be playing soccer or baseball or other sports, the recommendation is no more than 10 hours of organized activity per week. For a 7-year-old, for an 8-year-old, it should be 8 hours per week. For a 17-year-old, it should be 17 hours per week. That helps to give pretty good guidance in terms of how much individuals should be playing to prevent overuse. Now, really quickly, before we talk about some general workup, we're still going to see a subset of parents who said, I'm willing to subject my child to overuse injuries so that they can get to professional sports. You're even still going to get some parents, and I think it's important to show this data as well too. We know that the single sport specialization, this can be a whole nother talk, increases injury risk and burnout injuries and overuse injuries. And I like to tell individuals that you can't become a professional athlete unless you are healthy and on the field and preventing these overuse injuries. And I think the professional sports data really demonstrates this. We did a study here at UCSF with myself and one of our residents, my co-partner, Dr. Feely, where we looked at NBA athletes, and we found that multi-sport athletes participated in more games, experienced fewer major injuries, had longer careers than those who participated in a single sport. In the NFL as well too, we found that it's not we, but other researchers found that 80% of athletes who were invited to the combine were multi-sport athletes. And we look at baseball players as well too. And we found that those who actually had longer careers or less likely to get injured played multiple sports. So once again, even for those parents who come in who said they're willing to subject their children to these this kind of sports and are willing for them to burn out and have overuse injuries, even when you have to talk to them, perhaps you have to even tell them that, number one, this doesn't even lead to them having professional success. And number two, that as we'll talk about, it can lead to some significant injuries that may take some time to get better. So in general, the number one thing that I tell parents is that they should be playing multiple sports. It's this concept of active rest. And if they are going to be doing organized activity, they shouldn't play more hours per week than their age in that sport to prevent it. Now, in terms of putting it all together, how do we put this together in the clinic setting so that you can actually counsel parents and treat overuse injuries? So the goal really is you want to look for acute injuries and identify overuse. And a lot of times these go hand in hand. Yes, some of these athletes will get traumatic injuries where they're doing all the right things, but a lot of them will have a history of overuse beforehand that leads them to have these acute injuries. So the key history questions that I like to differentiate out an overuse injury from an acute injury is looking at the type of pain they may have. So when I take a history for them, if they have insidious and dull pain, I get a little bit more concerned about an overuse injury versus sharp and traumatic pain, which is more concerning for acute. Diffuse pain is usually more consistent with an overuse injury versus localized pain, although there can be some exceptions with that with specific pathologies. But in general, global overuse will give more diffuse pain. Pain before and after sports can be a sign of overuse versus during the sport. And a normal gait is usually very typical with overuse injuries versus locking, instability, or limp, which is more of your acute traumatic injury. And I think this is important so you can counsel parents as to cut down sports. We don't need to get advanced imaging for an overuse injury. Let's try to basically give it more time versus that acute injury where you may need to work it up more thoroughly. Other questions I like to ask is how many hours per week they're playing sports. If they're runners, how many miles per week they're running, how many pitches per week they're throwing, so get a sense of their volume. The number of different teams they're playing for. So a lot of kids may be doing 6 to 7 hours a week of organized sports with one team, but maybe playing for their school and maybe playing for multiple clubs. I think it's important to get a sense of what shoes they wear, if they made any changes, what inserts or braces they're wearing, medications, supplements, any history of prior problems, family history, grades, and emotional health. These are all important things to consider in your history. A lot of times I'll get questions about what's the key physical exam maneuver that we need to do. I say in general, if you're concerned about an overuse injury, where it hurts, will direct you to the injury 99% of the time. So there's not some special exam maneuver, et cetera, that we need to do. In terms of imaging, I still think that in this population, all patients should get an AP and laterally affected joint just to look at it to see if there's any abnormalities there. And I always use this example when I'm teaching the residents that a lot of time, even though what you may think is an overuse injury or maybe a traumatic injury can always present as one of those red flags. So the very first couple of weeks of my practice, I had this 10-year-old soccer player come in with 6 weeks of anterior knee pain, gave a very typical story for overuse. We got an X-ray, and I'm, initially looking at it. Oh, it looks like a normal X-ray. And then we say, oh wait, there's some periosteal reaction over there. What could that be? And the patient ended up having an osteosarcoma. So I think even though a lot of times we are hesitant to get imaging, just remember that a lot of times infections, tumors can present in individuals who are healthy and active. So just make sure to get imaging as well, just to rule out some of those pathologies. In terms of MRIs, particularly here in the US, we get a lot of parents will come in asking for MRIs. I really will reserve MRIs for your acute injuries or if they've failed non-operative treatment. And I've kind of shifted to more 12 weeks than necessarily 6 weeks. A lot of times when kids come back after 6 weeks, they've just started physical therapy a week or two ago, or they haven't really rested. So typically 12 weeks if they fail non-operative treatment. Another question we'll get a lot are what are the consequences of playing through the pain? Can my child still play even if they're dealing with an overuse injury? And the way I like to break it down is if they have no structural damage, but the pain will last longer, the consequence could be minor structural damage or a major risk of structural damage. And I like to quantify that with my patients. So in this first group, that's typically patients who have dull pain at the beginning of end of activity and none during activity. This is typically patellofemoral syndrome, IT band issues, or patellar tendonitis. Injuries that have a minor risk of structural damage if you continue playing, these are small meniscal tears or MCL, LCL sprains. And the major risk of structural damage kids, these are very easy to identify. These are your large surgical injuries that you don't want individuals playing on. So now in the last 10 minutes here, we'll talk about some of our top cases that we treat in terms of overuse injuries. I think the number one area that we're going to see the most are your apophyseal injuries, your apophysitis, okay? Now, as I like to say, these are when growing pains are not necessarily growing pains. A lot of times we like to say, oh, this is just related to growth, but this is related to being in the stage of development in which you are growing and then having overuse combined on top of it. So in terms of apophysitis, obviously the pelvis is one region where there's a lot of it, but in general, a lot of people ask, well, what is an apophysis? An apophysis is a growth plate where the muscle attaches and where bone growth is greater than muscle growth. So this is an area of high stress near these areas. And apophysitis is where irritation in the apophysis occurs due to tight muscles and overuse, and a lot of these go hand in hand. So, the most classic one we see is Osgood-Schlatter's, when the patellar tendon will pull very hard on the tibial tubercle apophysis, and they'll get a lot of swelling in that area. It's a very common injury we see in athletes. A little bit less common is your Syndergaard-Johansson syndrome. This is basically where the inferior part of the patella is pulled on by the patellar tendon as well too. Sometimes it's going to be mistaken for a fracture, a patellar sleeve injury, but most of these patients will come in without a history of trauma and will have pain right over that inferior pulled patella. Seaver's disease is the second most common overuse of apophysitis that I'll see after Osgood-Schlatter's. This is due to the Achilles tendon pulling very hardly on the calcaneal apophysis. You can get ischial tuberosity apophysitis, which is relatively rare. I don't see it as much, but that's due to the proximal hamstrings, particularly in soccer athletes who are running a lot or doing a lot of explosive activity. And once again, that gets mistaken for a fracture sometime. And this actually is the one that probably is the most chronic and can be very difficult to treat. And very rarely will I see Iceland's disease, which is the around the fifth metatarsal apophysis as well too in the foot. But sometimes once again can get mistaken for a fracture, particularly in a patient who doesn't have an acute presentation. So the key in general for these patients is they're generally between 7 to 12 years of age. They're skeletally immature. They have to be for the apophysis to be irritated. The Seaver's patients in general, what I found in my practice, are typically younger. They're 7, 8, or 9. And then the Osgood-Schlatter's, SLJ, and ischial apophysitis in Iceland's are usually much older. I think a lot of that has to do just how the ratio of how the foot grows earlier than those other areas. These typically are soccer and basketball players. It's always related to overuse. They're the kids who come in playing 15 hours a week. They've had pain for 6 weeks, and they're continuing to play, and they're going through a growth spurt as well too. And the key is that their pain over the bony prominences and not the tendon. Typically, this age group will not get pain in the tendon, but it'll present as such. So parents will come in and say, my kid has Achilles tendonitis, they have patellar tendonitis, when really the issue is at the apophyseal region, and it's not necessarily an inherent problem at the tendon. There can be an issue sometimes at the tendon where it attaches on bone, but there's not an inherent difficulty in the tendon itself. This is where they'll be sore with Osgood-Schlatter's. Hopefully most patients won't have that much hair at age 8, but an example of where they'll be sore. Severs, they'll typically hurt over the calcaneal apophysis where you're squeezing there. The key with Osgood-Schlatter's is that this will typically occur on the growth spurt, and they'll be very, very tender. In terms of treatment of this disease, it's the principles of rest, ice, compression, elevation. You want to avoid excessive activity. They want to do stretching, physical therapy, orthosis if they have flat feet, tendon straps, these patellar tendon straps on the lower right. And then that will help a lot of them. For Severs, very similar principles. In stretching and PT is key, particularly the Achilles complex. Heel cups, which are there on the top right, are extremely helpful for raising up the Achilles and taking pressure off it. Minimizing cleat wear in soccer athletes is extremely important. What you do need to worry about occasionally, in Osgood-Schlatter's being the one, is that individuals who have untreated Osgood-Schlatter's or continue to do activity can sometimes get tibial tubercle fractures. 1 or 2 kids a year I will see who come in with an acute tibial tubercle fracture who have pre-existing Osgood-Schlatter's. It does weaken the apophysis, and with repetitive activity without rest, this injury can occur. In terms of return to play in general, they want to have full motion, decreased pain, full strength, and can functionally go back to activity. I find that most of these kids either need home-based physical therapy or rest for 4 to 6 weeks to get the pain better. The next pathology is anterior knee pain. I think in general, patellofemoral syndrome can be in relation to tons of different things in terms of the exact pathology, but I think in general, we call it just quote unquote irritation behind the patella. Generally, these patients won't have trauma. They have dull pain around the kneecap. It feels like sandpaper. They're playing sports all the time. Sitting down for long periods of time gives them pain. Their exam is typically very benign, but they lack flexibility and core strength. And there are a lot of different risk factors for anterior knee pain, which is one of the most common overuse syndromes. But in general, it's training errors and overuse. One of the best ways to identify mechanical factors which cause them this problem is to have them do a single leg squat. They'll basically fall into valgus when they do that. In the context of doing that repetitively, and overuse stresses the anterior knee and has been associated with anterior knee pain. Another thing to test for flexibility is look at their popliteal angles. A lot of lack of flexibility is in the hamstring region for these kids, and that's a risk factor for them developing anterior knee pain. Another thing you can have them do is do a plank. They'll lack core stability, which is another risk factor in the context of them doing excessive activities. In general, as mentioned before, I'll get an x-ray just to rule out any osteochondral lesions, and only an MRI if they're not improving. The treatment is rest, physical therapy, working on core and hip strengthening, stretching, and orthoses for the feet as needed. A lot of kids will come in and say, well, I have great strong quads, I have strong hamstrings. Why are they making me do core work and physical therapy? We know that core work and pelvic stability is associated with decreased risk of anterior knee pain, particularly in the context of overuse in young children. And once again, we go through the consequences of pain. I think in general with anterior knee pain, if they're able to get it controlled, they can continue to work if they decrease the amount of overuse that they're doing. The only time that surgery is ever indicated is if they have plica syndrome, which is not necessarily related to overuse, but it's one common cause of anterior knee pain. And once again, they have to fail extensive physical therapy for them to undergo this surgery. Really quickly right now, I'll touch on Little League shoulder and Little League elbow. What Little League shoulder is generally overuse of the shoulder in throwing athletes. A lot of these are the classic kids that come into my clinic where the parents have been pushing them to pitch. They throw every day of the week. In their tender patient over the anterolateral shoulder, they have decreased rotator strength and they have no instability. This demonstrates a radiograph that shows what Little League shoulder is. It's irritation of the proximal physis, and you can see how it's widened there on the image on the left. You should never get an MRI for this pathology, but you can see the irritation and growth plate here on MRI as an example, which is the pathology. Individuals this age don't get rotator cuff tears. They don't get labral tears. This is simply due to overuse. Now, in terms of treatment options for this, it's important just to take a step back and understand what type of overuse is occurring. And the overuse that's occurring is that they're pitching too much, they're not resting, and they're throwing very specialized pitches. It typically is insidious in onset, and they'll have signs that look like impingement, but they're not going to be ones that actually get impingement. Other things that people worry about, which you don't have to worry about, are rotator cuff inflammation, which will happen in older patients. Most of these patients won't have instability, they won't have internal impingement, and they won't have a tumor, obviously. On plain films, they'll show separation of the proximal humeral physis. If you're concerned or you can't tell, get contralateral films to look for that widening. And once again, MRI only if they're failing conservative treatment for 3 months. The treatment is stop throwing for 6 weeks. You have to counsel these parents. They need to stop throwing, get them into physical therapy to identify any biomechanical deficits. If after 6 weeks of rest and PT, they can begin throwing if they're pain-free, and they can return to pitching at 3 months. So it's a long period of time off. Surgery is not indicated. In this return to throw program after 6 weeks of rest is what we use here. It's very extensive and prevents these individuals from getting irritation or further injuries down the road. This is the recommendations that baseball here in the United States has made for kids in terms of pitching. If parents stick to this, then there's a very small risk of them actually getting it, as opposed to parents who aren't following this. Little League elbow is on the same spectrum as Little League shoulder. A lot of these times, these kids will potentially have an acute event where the pain starts. But once again, it's very similar to Little League shoulder patients where they get acute irritation of the medial epicondyle apophysis, and they're going to be tender patient over the medial side of the elbow. It's very scary for a lot of parents because they can feel that this may be a ulnar collateral ligament injury, but it's typically in skeletally immature individuals. And you can see there in that image how there is widening of the medial epicondylar growth plate. It can appear to be almost like a medial epicondyle fracture, but it typically is not accompanied by a large amount of swelling and a significant amount of displacement. In general, we see this in a little bit older patients. We know that epicondyle ossifies between ages 5 and 7 and completely ossifies between 14 to 17. The apophysis is weaker than the muscle, tendon, and bone, and it causes widening, separation, and irritation. It's sometimes insidious onset. Sometimes if they have a history of trauma, you worry about an avulsion. They will note that they have decreased performance, they're a little bit stiffer, and they're tender right over that medial side, right over the bone. If they're more diffusely tender, it's typically a muscle injury. If they're laterally tender, it could be an osteochondral injury. And if they have laxity, that's when you get worried about ulnar collateral ligament injury. A lot of this has to do with throwing mechanics. And if there is issues with them continuing to have this pathology, it's important to look at that. But this is basically what happens. You get apophysitis from tension and capitellar osteochondral lesions from compression. And that's where the pathology lies in for these apophyseal injuries. There's a large differential diagnosis for elbow pain, but I think the key thing is if they're tender over the medial epicondyle and they have x-rays which demonstrate it, you pretty much have your diagnosis clinched. Once again, you have to image both elbows. If you're concerned, you look for a widened apophysis. And only if x-rays are negative do you get an MRI if the pain continues or they're tender laterally. The same treatment as you rest. Don't throw for 6 weeks. And then after 6 weeks, you can begin a return to throw program. If they continue to have this recurrently, you sometimes have to tell them they have to stop pitching. And if they have an avulsion fracture, then you want to consider surgery. And the very last pathology we'll talk here in the last 30 seconds is medial tibial stress syndrome, which we know is shin splints. The differential diagnosis for a young athlete who comes in with tibial pain, if they're diffusely tender, it's typically this medial tibial stress syndrome. If they have focal pain, it's a stress fracture. And if they have pain that's only present with exercise and stops with rest, then you worry about exercise-induced compartment syndrome, which is very rare. If the patient has pain, I'll get a tibia x-ray to rule out a stress fracture. Once again, it's very rare. And if they're not getting better with rest, then you get an MRI, okay? The treatment for this is typically the same component. We see it a lot in runners, particularly who are between 14 and 17. They have to rest. They do ice massage, anti-inflammatories, taping, which has been used very effectively, assessing their shoes, getting them orthotics, and modifying their activity, decrease the amount they're running, they're doing, and they'll get better. And particularly what I'll say is they have to decrease their mileage by 25% and then slowly ramp back up and do non-impact activities to help them get better. And if it's really, really severe, you can get a cam walker and cessate their activities. So once again, thank you. That was a whirlwind of pediatric sports and overuse injuries. I think the important thing to note is that counsel your kids to take time off, identify any mechanical abnormalities that they have, and understand it's more important for them to be participating in an unorganized fashion so that they don't get these injuries. Thank you.
Thank you, Nirav, for yet another fantastic lecture. Just a couple of questions.
Sure.
Do you think one of the reasons for having an overuse injury is the differential growth between the bones and muscles? Because the bone grows faster and muscles do not keep pace with it.
Absolutely. And I think that it's the same thing for, even when I see kids in clinic who have growing pains who aren't being athletic, I definitely think that the bones are growing much faster. The muscle tendon unit can't keep up, and there's microinflammation and pain over there. So absolutely. I think particularly when kids are going through rapid growth, that's when they're most susceptible for it. And I think a lot of parents will tell me, well, yeah, my child has grown a lot recently, and that's where the pain's coming from.
Thank you for that. And when you talk about little leaguer's shoulder, right, is it similar to a stress reaction to the growth plate? Does it result in a suppose you don't treat it early, can it result in a permanent growth plate damage?
That's an excellent question. So we do have that concern. Actually, the one area where we have seen that a lot is a similar pathology, which I didn't talk about in the gymnast's wrist. We see that a lot in gymnastics. And I've actually seen cases of distal radial physeal injury, basically stops growing due to this, and they get ulnar overgrowth. So for the good news is that for most throwing athletes, they can't effectively throw, so they usually will stop. I use that to counsel parents, but gymnasts, they just keep doing this kind of load. And I have seen at least maybe 1 to 2 individuals a year who have distal radial physeal arrest from that repetitive activity. So that definitely is a risk. And that sometimes is what you have to tell parents, that, look, you have to stop because there's that risk of the physis injury, or a traumatic issue like with Osgood Schlatter's, where you can get a tibial tubercle avulsion. Yeah.
And with respect to prevention, do you advise the kids not to play in multiple teams and just focus on a just single team?
I do, yeah. So I think that's where the problem comes in. Kids will say, look, I'm going to play for my school. I'm going to play for this club and that club. So I think if they are going to play a sport, just concentrate on that one team, both for the overuse components of it. And also it allows one coach to be monitoring activity. I think a lot of times it becomes difficult when multiple coaches are telling you different things. So yeah, concentrating on one team and then doing multiple activities throughout the year is the important thing.
Nirav, Senthil is also in our Zoom room. Senthil is a staff orthopedic surgeon based in Texas. Senthil, your questions to Nirav.
Nirav, it's an excellent presentation. Actually, I practice adult orthopedics, but there's a lot of information which even I'm not aware of. So when you first see the patient with an overuse injury, with your experience, you know it is overuse, but do you do any screening, nutritional screening, and do you look for ligament laxity to prognosticate treat? What else? What's your protocol like?
Yeah, so I typically, just part of my physical exam, I always get do a Baton hypermobility score on them, just kind of see if there is some degree of ligamentous laxity. And then I think particularly in some of the female athletes, or where I'm seeing stress injuries like stress fractures, I'll do a vitamin D and calcium workup and occasionally send them to endocrine. But I do think that when the story doesn't necessarily fit, or I get the individual in who's not necessarily healing from their overuse injury, that's where I get worried about the ligamentous laxity, because those patients will have pain for a long period of time, or I'll get a nutritional workup for them. And also just generally, I think a lot of the athletes don't know how to eat and drink, et cetera. So even from a basic level, teaching them about protein and nutrition is sometimes I'll either do it myself or refer them over to a nutritionist.
That's great. And other thing is, a lot of kids want to just jump into playing. What about any specific warm-up protocols and cool-down protocols you tell them?
Yeah, so one of the things that I'll recommend, that's a great question, is that they should be warming up and cooling down for 10 to 15 minutes, both before and after activity. And I think that for warm-up activities, there are a lot of, one great warm-up activity is the ACL prevention program activity, where it's basically 10 to 50 minutes of exercises that, it prevents ACL injuries, but it's a great workup as well too. So I tell kids to dynamically work up. I think a lot of kids will either jump into activity or just sit there and stretch. So I think running, moving the body, getting the body warmed up, and then stretching after activity is really, really key. Too many kids just get off the field, take off their cleats, and hop in the car when their parents come. So I think making sure they're doing that stretching and cooling down is really important.
And obesity is increasing in pediatric population, especially with the COVID epidemic and pandemic. So how do you kind of bring up the topic, and what kind of discussion you focus on that?
Yeah, it's interesting. So I think before the pandemic, it was a little bit more difficult to bring that up, particularly in our population, because it's always a very sensitive subject. It's been a lot easier with the pandemic because I think a lot of people recognize that they've been less active. So one of the things I'll tell in general with kids is that, look, you're getting back in activity, your joints will experience more stress with increased weight, and a lot of pain is coming from that increased weight that may be on the joints, et cetera. So with a lot of kids who aren't necessarily playing a lot of sports, I will encourage them to get active. And part of the way that I tell them is try to be active in some way for 30 minutes a day. Or a lot of them, like the Fitbits or Apple Watches, will have them now. And I'll say, you should try to get your 10,000 steps in a day. So I think if you give kids a goal for activities, they're a lot more responsive to it. And typically it's not necessarily diet sometimes with these children. I think it's more the lack of activity. So I think it's easier to counsel them to say, hey, here's some goals. Why don't you do that every day? Because we do get a subset of kids who come in who say, my body, my joints hurt, and it's not because they're doing too much, it's because they're not doing enough. So it's on the other end of the spectrum.
That's great. That's nice. Thank you. Thanks for the information. I don't think I have any more questions, Nirav. Wonderful presentation.
Thank you, Nirav. I think that's all the questions that we have for this session. Fantastic lecture. I'm sure this lecture is going to benefit thousands of surgeons all over the world. Thank you so much for joining in.